Okay. So today I'll be talking about physiology of vestibular system and its assessment. Okay. So a brief recapitulation: the components of vestibular system. Do you hear me?
हजुर सर सुनिरहेछ सर
Okay, one or two keep communicating with me, okay, so that I can get to know that you are following. So the vestibular system, it has got basically two components, peripheral and central. Okay, the peripheral is the ear, which contains the inner ear. Inside that there is membranous labyrinth, semicircular ducts, utricle and saccule, and membranous labyrinth and vestibular nerve. Okay, from there it goes to the central component of vestibular system, which is made up of nuclei of and fiber tracts in the CNS to integrate the vestibular impulses with other system to maintain the body balance. So vestibular system, there are two types of peripheral receptors. One is cristae and the other one is macula. Okay, so crista or cristae, it is located in the ampullated ends of three semicircular ducts. It responds to angular acceleration. And macula, it is located in otolith organ, utricle and saccule. The macula of the utricle lies in its floor in a horizontal plane, whereas macula of saccule lies in its medial wall in a vertical plane. So macula, what does it do? It senses position of head in response to gravity and linear acceleration. So a brief anatomical recapitulation of structure of a crista. It is a crest-like mound of connective tissue on which lie the sensory epithelium. Cilia of sensory hair cells project into the cupula, which is a gelatinous mass. Okay, and then there are two types of hair cells, type 1 and type 2. These types are based on the shapes. Okay, type 1 is flask shaped with a single large cup-like nerve terminal surrounding the base, whereas type 2 it is cylindrical with multiple nerve terminals at the base. Kinocilium, the kinocilium, it is a single thicker and located on the edge of the cell. And sterocilia, they are multiple and thin. So structure of macula. The macula consists of sensory neuroepithelium. It is made up of again type 1 and type 2 cells. Okay, and above the sensory epithelium there is an otolithic membrane. So this membrane is made of gelatinous mass on which crystals of calcium carbonate, otolith or otoconia, are present. The cilia of hair cells project into this gelatinous layer. So linear gravitational and head tilt movement causes displacement of the otolithic membrane and stimulates the hair cells. Now semicircular canals, these are three in number. They lie at right angles to each other. The semicircular canal, which lies at right angle to the axis of rotation, is stimulated the most. For example, the horizontal canal will respond maximum to the rotation on a vertical axis. Now, nystagmus is abnormal jerky movement of the eye, which is produced if there is imbalance in the vestibular system. The direction of nystagmus is determined by the plane of canal which is being stimulated. Okay, horizontal canal, if it is stimulated, the direction of nystagmus will be horizontal. For posterior canal, it will be vertical, and for superior canal, if it gets stimulated, then we get rotatory nystagmus. The flow of the endolymph stimulates semicircular canal by displacing the cupula. Okay, so if it is towards the cupula, it is ampullopetal, and if it is away from the cupula, it is ampullofugal. The fast component of nystagmus is opposite to the direction of flow of endolymph. Now coming to utricle and saccule. Okay, so utricle is stimulated by linear acceleration and deceleration or gravitational pull during head tilt. Sensory hair cells of macula lie in different planes and are stimulated by displacement of otolithic membrane. The function of saccule is similar to utricle, but experimentally the saccule also responds to sound vibrations. Now vestibular nerve, which is a part of peripheral vestibular system, it is the vestibular or Scarpa's ganglion. It is situated in the lateral part of internal acoustic meatus and it contains bipolar cells. The distal processes of bipolar cells innervate the sensory epithelium of the labyrinth, whereas the central processes they aggregate and form the vestibular nerve. Now vestibular pathway, the fibers of vestibular nerve finally end in the vestibular nuclei. Okay, so there are 4 vestibular nuclei: superior, medial, lateral and inferior, and some go to the cerebellum directly. Okay, the afferent fibers to these nuclei come from peripheral vestibular receptors like semicircular canal, utricle and saccule, from cerebellum, from reticular formation, spinal cord, from contralateral vestibular nuclei, and information is integrated with information from other somatosensory systems. Whereas the efferents go to the nuclei of cranial nerve 3, 9, 11 via the medial longitudinal bundle, which is also the pathway for vestibulo-ocular reflexes. Motor part of the spinal cord, vestibular spinal fibers, coordinates the movement of the head, neck and body, maintaining the balance. Cerebellum, the vestibulocerebellar fibers, autonomic nervous system, vestibular nuclei of opposite side and to the cerebral cortex. So are you guys following? सुनिरहेको छ? Am I audible?
Yes, sir. You're
Okay,
audible.
so
Yes, sir.
maintenance of body equilibrium. How does the body stand in an equilibrium? Okay, so there are mainly 3 systems: vestibular, visual and somatosensory. So as you can see in the picture, the inputs will go from the vision, eyes, visual input, and if there is any rotational force or if the gravity is pulling, then those input will go from the semicircular canal, utricle and saccule, and from this proprioceptive area. For example, while you are pressing upon on your feet, then these inputs go into the central nervous system, and after that they give some reflexes. Yes, after that they give some reflexes, ocular reflex and postural control. Okay, any imbalance in this will cause nausea and vertigo. Okay, so in the CNS the main things that are involved are cerebral cortex, brainstem and cerebellum, and then the ocular from the eyes, vestibular from the ears and proprioceptive from our feet, let's say. Okay, so all these are the inputs in order to balance the body. So there are certain clinical tests and laboratory tests which are done in order to assess the vestibular system. So the clinical tests being spontaneous nystagmus, fistula test, Romberg's test, gait, past pointing and falling, positional test, and test of cerebellar dysfunction. Some of these you have already read in your second year physiology classes as well. Okay, and the laboratory tests include caloric test, electronystagmography, optokinetic test, rotation test, galvanic test, and posturography. The advantages of vestibular test are it helps in establishing a diagnosis. It helps to locate the cause of vertigo, okay, whether it is central or peripheral. So for documentation, for lateralization, and it also assists in devising a treatment plan and also aids in long-term management. So some common clinical tests for vestibular functions include spontaneous nystagmus, okay, as you can see in this demonstration. So what is spontaneous nystagmus? You can see that these eyeballs, they are moving rhythmically, and the movement is oscillatory and involuntary, okay. So the definition is involuntary, rhythmic, oscillatory movement of eyes is nystagmus, okay. So this one is horizontal nystagmus, but it can also be vertical or rotatory, okay. So there are two components, the fast component and slow component. In this, the fast component is going towards the right of the patient, right side of the patient, and slow component is towards the left, okay. And then the intensity of nystagmus, you can see that in this picture, the intensity, it looks quite intense, okay. So the second thing that you should understand is degree of nystagmus. First degree, second degree, and third degree. First degree is weak and it appears when looking towards the fast component. Second degree is while looking straight ahead. And third degree is stronger looking towards the slow component. Okay. The elicitation of nystagmus, it occurs whether in supine or sitting position, and the examiner's fingers will be 30 centimeter away from patient's eye in central position. After that you move right, left, up and down, but less than within 30 degrees from the center, okay. Within this range, if there is nystagmus, that is physiological nystagmus. I mean beyond this range is physiological nystagmus. Within this range, if you elicit nystagmus, then usually that is pathological. Types of nystagmus, it can be peripheral nystagmus or central. Okay, peripheral if it is associated with labyrinthine lesions or eighth nerve lesions. Okay, and central if it is associated with central neural pathways, vestibular nuclei, brainstem, and cerebellum. Again, there are two types of lesions: irritative lesions that irritates the vestibular system. In that case, the nystagmus will be towards the same side, and then paretic lesion. In this case, the nystagmus will be towards the opposite side. So vertical, rotatory, it can again be vertical, rotatory, disconjugate, or mononuclear if the cause is central. So central causes, if nystagmus is happening because of disorder in the central nervous system, it can be vertical, rotatory, disconjugate, or mononuclear. So this table differentiates peripheral nystagmus from central nystagmus. Okay. So latency, how much time does it require to elicit the nystagmus? For peripheral it is 2 to 20 seconds, whereas for central there is no latency, it is happening all the time. Okay. So duration for peripheral it is less than 1 minute, for central it is usually more than 1 minute. Direction, it is peripheral nystagmus, it is fixed towards the undermost ear, whereas in central nystagmus it is changing. Fatigability, it is peripheral nystagmus, it is fatigable. Central nystagmus, it is non-fatigable. Okay. And accompanying symptoms, in peripheral nystagmus there is severe vertigo, and in central there is non or slight vertigo. Fistula test. So what do we do in fistula test? Induction of nystagmus by pressure changes in the external auditory canal. Okay, so we do something so that the external auditory canal air pressure changes. It is transmitted to the labyrinth, and from there the labyrinthine stimulation causes nystagmus and vertigo. Okay, so this test is performed by either using something known as Siegel's speculum, in which you push air through the Siegel's speculum, or it can also be performed by giving intermittent pressure on the tragus. So in normal people, it is negative, there will be no nystagmus, or in dead labyrinth there will be no nystagmus. And the test is positive in cases if there is erosion of semicircular canal, if the patient has undergone fenestration operation, post-stapedectomy fistula, or round window membrane rupture. So false negative fistula is seen if a cholesteatoma is covering a fistula, and false positive fistula test is known as Hennebert's sign. It is seen in congenital syphilis. It's also known as Hennebert's sign. Romberg's test from your physiology classes, I think you remember, you asked the patient to stand with feet together and arms by the side with eyes open first and then closed. In case of peripheral vestibular region, the patient will not be able to stand straight and the patient will sway towards the side of the lesion. Whereas if it is central lesion, then the patient will show random instability. So gait, you ask the patient to walk in a straight line to a fixed point with eyes open first and then closed. The patient deviates to affected side with eyes closed in case of peripheral vestibular lesion. Now Dix-Hallpike maneuver. Okay, this is important. This is sometimes asked in your exams as short notes. Okay, so this is used to provoke nystagmus and vertigo. It is commonly associated with BPPV, which stands for benign positional paroxysmal vertigo. So what we do is we turn the head 45 degrees to maximally stimulate the posterior semicircular canal. The head is supported and rapidly placed into head hanging position for 20 seconds, producing nystagmus. Frenzel classes eliminate visual fixation suppression of response. So you can see in this picture the head is turned 45 degrees to the left side of the patient, and then you bring the patient from sitting position to supine position with head hanging almost 20 degrees below the couch. So Dix-Hallpike test is positive when we get an upbeating nystagmus towards the stimulated side. The nystagmus usually lasts for 15 to 45 seconds and it has a latency of 2 to 15 seconds and it is fatigable, that is, it fatigues easily. Now other laboratory tests for vestibular function. First, caloric test. So for vestibular oculomotor function, we do bithermal caloric testing. It is established and widely accepted method of vestibular testing. It is most sensitive test of unilateral vestibular weakness. It was first discovered by Robert Barany in 1906. What happens is the patient is positioned 30 degrees from the horizontal with horizontal semicircular canal is made vertical, allowing maximum stimulation. Okay, and then cold and warm water or air is flushed into the external auditory canal. The cold water will be 7 degrees below the body temperature and warm water will be 7 degrees above the body temperature, and it is flushed for 40 seconds and the latency is 2 minutes. So what we elicit is warm water hits the fluid in the semicircular duct. The specific gravity of fluid falls. As a result, the fluid rises, that is moved towards the ampulla. So it results in nystagmus with quick component towards the stimulated side. Whereas in case of cold water, the endolymph moves away from the ampulla and produces nystagmus in the opposite direction. So this you can remember with the mnemonic cows. Okay, cold opposite, warm same. That is the direction of nystagmus. So the stimulation is usually given in 0.002 to 0.004 Hz range. Visual fixation should reduce strength of caloric responses 50 to 70% and the percentage caloric paresis is 100%. And then this is the formula. Total response you can get by sum of all response. Total response is right cold plus left cold plus right warm plus left warm. should be 20 or greater. In case of canal paresis, the duration of nystagmus is reduced both by hot and cold water. Directional preponderance, the nystagmus towards one side is shorter duration than that of the other. So the formula is right beating minus left beating divided by total. So it should be 35% or less. Caloric test is used to diagnose cochlear function, lateral semicircular canal disease, eighth nerve palsy, vestibular function, cerebellar function, and brain damage. So there are other variants of caloric test as well. For example, if the patient has got tympanic membrane perforation, we cannot use water. So we use cold air test. So there is another variant in which we use cold tap water test at 10 degrees centigrade. Cold air test is usually done in cases of active middle ear infection, perforation, or mastoidectomy cavity. Oxygen or compressed air, Dundas Grant tube, coil of copper tube cooled by ethyl alcohol. So that produces nystagmus which lasts for around 30 to 60 seconds. Then there is something known as electronystagmography. Okay, it relies on the vestibular ocular reflex to test the peripheral vestibular function. But its limitation is that it assesses only the horizontal semicircular canal. It is the only test assessing each ear separately and can give site of lesion localizing information. So you can see that in the picture a pair of electrodes above as well as below the outer canthus is kept, and then there is a ground electrode at the forehead. So with these electrodes you measure the electronystagmogram. Limitations of this, it tests only the horizontal semicircular canal. There is no information regarding posterior or superior semicircular canal, utricle or sacral, and the advantage is that it detects nystagmus which is invisible to the naked eye, and it also gives accurate analysis of nystagmus. Now there's something known as optokinetic test. The patient is asked to follow a series of vertical strips on a drum moving from right to left and then from left to right. Okay, so the nystagmus is produced with slow component towards the direction of the moving stripes. Okay, and in cases of central lesion you get abnormal nystagmus. There is something known as rotational chair testing. It is the gold standard in identifying bilateral vestibular lesions. It is used to monitor for progressive bilateral vestibular loss. It is useful in meatal atresia, and it is useful in testing children that will not allow caloric irrigations. So Baroness chair, you can see that is the chair with head erect, eyes closed. Chair is turned in 10 circles in 20 seconds and suddenly stop. So the direction of nystagmus will be opposite to the direction of rotation. So rotatory chair test, it is the most useful and passive rotational test. The patient rotates, axis of rotation is vertical and passes through the center of head. Stimulates the lateral semicircular canal, horizontal eye movements are recorded. There is one more test which is known as computerized dynamic posturography. You measure each components of balance, visual, proprioceptive, vestibular, reflex muscle response by patient's ability to stand in increased difficulty situation. So there are two parts, sensory organization test and motor control test. So this picture shows posturography being done. That's all. So in today's lecture class, we learned about physiology of vestibular system.